evidence-based optimization strategy. See, this is the scenario of the diabetes in India. Type 2 diabetes starts at younger age in India. So we are getting at 20s, 30s. Indians have low beta cell mass and the high insulin resistance. For a given BMI, we are having the more insulin resistance. At the same time, our pancreas is not producing enough insulin to tackle our hyperglycemia. These two are very common in the Indian population. That is the reason we need insulin initiation in most of the type 2 diabetes at an early age. Micro and macrovascular complications appear early in the Indians because we are getting the diabetes in younger age group after 5 years or the 10 years or 15 years of the diabetic life. So obviously, because of the uncontrolled diabetes, we are inviting both micro and the macrovascular complications. 1 in 3 patients with diabetes will have early onset of the CVD. So the commonest cause of the death in diabetes is the myocardial infarction. So almost 33% of our diabetic individuals will have the cardiovascular disease, either ischemic heart disease or the heart failure or the CVA or the peripheral vascular disease. See, glycemic control in the Indian patients is very, very poor. 67% of the patients in India, they do not reach their HbA1c targets. Even though we know that the fasting blood sugar around 100, BP blood sugar around 150, HbA1c around 6.5, it is very easy to say but very difficult to achieve in most of our diabetic individuals for several reasons. So if you see the statistics, so the nearly 70% of the people, they are above the target range of our HbA1c. That is the reason India is not only the diabetes capital of India, but also the diabetes complications capital of world. So type 2 diabetes reduces the life expectancy very significantly. So it is true in most of our cases, but sometimes having known that they are the diabetics, they will be very good in their dietary approach and the exercise program, and they may increase the lifespan and the health span also. But in general, most of the people in diabetics in Indian population, they die prematurely because of the lot of the complications. If they get the CKD, if they get the MI, if they get the PVD, if they get the amputations, if they get the proliferative diabetic retinopathy, so obviously life will be very miserable. Increasing complications and the comorbidities in patients with the diabetes. So nearly 32% of the people will have the CVD. More than 40% of the people will have the CKD. The highest incidence of the prevalence of the CKD in the diabetes in India to the tune of about 17 to 18%. Unfortunately, 88% of the diabetes people are overweight or the obese. So that would be the another reason for our increased insulin resistance. And 42.28% of the people with diabetes have the metabolic syndrome. There is a cluster of all the 4 diseases. A lot of the people are having the depression also, along with the diabetes. So they are not depressed with the diabetes, but they are depressed with the diabetes complications. See, the cardiovascular health in patients with the type 2 diabetes, you mean to say cardiovascular health means 2 diseases here, atherosclerotic and heart failure. So there is about 2 to 4-fold rise in the occurrence of the coronary artery disease and about 2 to 8-fold increase in the incidence of the heart failure. The renal health in patients with the type 2 diabetes. So the diabetes means vascular health, diabetes means renal health. See, unfortunately, 44% of the people with the diabetes will have the CKD, and controlling the high blood pressure is the key factor in slowing this disease. So in all the diabetic individuals, to give them a good quality of the life, if they happens to be hypertensive, so the control of the hypertension is also equally important to avoid the long-term complications. So type 2 can be considered the cardio-renal metabolic disease. So when you are dealing with case of the diabetes, so don't be happy with the blood sugars alone. So please concentrate the metabolic factors like your hyperglycemia, insulin resistance, obesity, lipids, etc. And also the renal. Renal means not only your elevated creatinine levels, but also your proteinuria and also electrolyte imbalance. And if you see the cardiology, so not only the hypertension and ischemic heart disease, but also the heart failure and acute coronary syndromes. So early intensification is very much needed. So don't static. If you start one drug today, so don't be with the same drug for another 5 years or 10 years. So every visit you have to intensify the diabetes management because diabetes is an aggressive, dynamic, and progressive disease. So a combinational approach to address the multiple pathophysiological mechanisms, glycemic and also the cardiorenal benefits, and reduce the occurrence of the hypoglycemia or the weight gain. And the oral option is always advisable and also palatable for most of the patients, but that doesn't mean that you should not use the insulin. So insulin is also very much needed as and when required. So early intensification with the cardiorenal protection and the minimal side effects is very much needed. So this is the best slide I think today's talk. So what are the priorities for all of us? So good glycemic control, good. Reduce the blood sugar with your OHA or with insulin or with the dietary approach or with your exercise or yoga, meditation, etc. So don't be happy with the good glycemic control. Please address the comorbidities. Suppose if the person is overweight or the obese, so reduction of the body weight. If the person happens to be hypertensive, control the hypertension. If it happens to be a dyslipidemia, control the dyslipidemia. If it happens to be a renal etiology, so control the renal parameters, etc. And finally, address the complications. So it is your duty as a diabetologist or a physician or a obesity specialist, etc., whatever may be the specialty. Whenever you dealing a case of the diabetes, address the complications. See, the complications are mostly silent. So it is your duty to identify the complications at an asymptomatic stage. So even though the patient is an ischemic heart disease, he may not complain you about the dyspnea or the chest pain. So it is your duty to identify the early ischemic heart disease by means of your TMT positivity or your troponin or your anti-proBNP to rule out the heart failure, etc. In the same way, identify the early nephropathy by means of your microalbuminuria or the urine proteins or your albumin creatinine ratio or early rise of your creatinine. You identify the fatty liver by your SGPT, SGOT, or fibroscan, or ultrasound abdomen, etc. So these three are very important. So identify the hyperglycemia, control it. Identify the comorbidities, control it. Identify the complications, attack it. It is an index case. A 54-year-old male, a government employee, is having the complaints of increased thirst, frequent urination, and fatigue. Is an hypertensive for the last 4 years. Is an occasional smoker. Also diabetic 5 years. Mother had gut infarction at the age of 52 years. So this is the history of that. So history says that around 50 years of the age group with a hypertension of 4 years and diabetes of 5 years, occasional smoker, and a strong family history of myocardial infarction prematurely. The mother had at the age of 50 plus. What drugs is getting? Is getting metformin, excellent drug to tackle insulin resistance. Is getting the temesartan, very good drug to tackle the hypertension, and is getting also the amlodipine. So 10 milligrams probably. So a two drugs are required to control the blood pressure. So temesartan and calcium blocker. And workup, we have seen the BMI is very high. So ideal BMI is 23. So it is 29. Waist circumference is 100. So ideal is 80 centimeters in the female and 90 centimeters in the male. So it happens to be a male. The waist circumference should be less than 90. Blood pressure is 140/90. In spite of the temesartan 40 and the amlodipine. So you have to reduce the BP here 140/90 to your target of your 140/80 or at least 130/80. So you have to increase the dose of the temesartan to 80 mg, or you can add a dilutive like your chlorothalidone or hydrochlorothalidone, maybe 6.25 the 12. His pulse is okay, so you need not add beta blocker at this juncture. Suppose if the pulse is 90 or 100 or 110, that shows tachycardia. So then there is a role of beta blocker to reduce his tachycardia. A1C is 8.5, so you are not happy. Your goal is 6.5. So the metformin alone is not sufficient. He is getting only metformin 1000 milligrams. Fasting is 155, BP is 210. So both are increased. Much more is the fasting blood sugar. Total cholesterol is 211, the high. LDL is 130, very high. Nowadays, a combination of the diabetes and hypertension with the strong family history of the myocardial infarction. Your goal of LDL is 55, not 100, not 70. So 55 is a high risk candidate. HDL is 41, so it's good for the males. More than 40 is good, but very few people of Indian origin will have the HDL more than 40 or more than the 50. 80 to 90% of our people are having the HDL at lower level. Triglycerides 180, even though the normal is 150 is okay. USER, urinary albumin creatinine ratio is 150 is high, normal is less than 30. So he's also having the nephropathy. Creatinine is 1. So this he is having the CKD. Even though the creatinine level is the normal, once your proteinuria is there more than the 30 for more than the 3 months. So that is also a definition of CKD. Your GFR, calculate the GFR is 75. So already in the stage 2 CKD. No elevation of the liver enzymes, so you are ruling out the fatty liver. And exercise treatment test is the positive. It is asymptomatic, but is the positive. See the case. It is a very typical and Godavari patient. So in asymptomatic with a strong family history of the myocardial infarction, a diabetic and hypertensive, when you are working up, so you diagnose him as an ischemic heart disease, asymptomatic ischemic heart disease, and also the nephropathy, and also the dyslipidemia, and also uncontrolled blood sugars, and also uncontrolled blood pressure, and also obesity. So you see this is workup, you will get all these things. So if you concentrate only on the blood sugars, if you write, so you increase the metformin is getting it. If you add some glimepiride or if sitagliptin or SGLT betas, that is not sufficient. So here you have to add the statins also, high intensity statins. Here you are supposed to increase the dose of the telmisartan also because he's having urinary albumin creatinine ratio 150. So this 40 mg is not sufficient for him. So you can go up to the 80 mg. So this is how you have to deal these cases. So screening for the cardiorenal metabolic status, measurement of the BMI is very, very important. Metabolic syndrome, so all the four, liver fibrosis to rule out your fatty liver, urinary creatinine ratio, creatinine levels, etc. And subclinical heart failure. So this LVH and your echo will tell you. Suppose if the patient is also having some breathlessness or orthopedy or dyspnea or pedal edema, etc. So get the NT-proBNP that will rule out your heart failure incidents. So lifestyle management is very important. So diabetes means first lifestyles. So your dietary modification, etc., etc. Smoking cessation in any way. Physical activity, very good physical activity. Still 60 minutes of walk per day, 7/7. Diet management. So the more complex carbohydrates, more protein, less saturated fats, etc. And essential treatment, lipid management with your statins, and glycemic control with your metformin, with your SGLT inhibitors, with your gliptins, etc. Blood pressure reduction with your ARP, with your Kashmir blocker, with your diuretic. If the patient is also having a tachycardia or compelling indication to use the beta blockers like ischemic heart disease, again your metoprolol or bisoprolol, and weight management. Where your dietary management or your exercise or nowadays your Monjulo, that is your tetrapadine injections to reduce your body weight. And essential treatment for the organ protection. This is the very important. As a physician, as a doctor, as a professional, so please initiate an SGLT inhibitors in all your diabetics to have your target organ protection. GLP-1 receptor regulates if the patient can afford. So now you have the tetrapadine, now you have the Wegovy, that is your injectable semaglutide, you have the oral semaglutide, Ribelsus, etc. And RAS blockade with your Ramipril or with your telmisartan, and non-steroidal mineralocorticoid receptor antagonist like phenerone. So that is a beautiful drug. Last year we had a CME on the phenerone, Keratium. So that is also very useful. And available in the two strands, 10 milligrams and the 20 milligrams. Depending on your GFR, you can use this phenerone. If the GFR is less than 25, use 10 milligrams. When it is GFR is more than 25, you can start with the 20 milligrams of the phenerone. So these four drugs are very, very important to give you organ protection. So early and coordinated treatment is crucial to improve the patient outcomes and the quality of the life. So now back to the SGLT inhibitors, they are the class benefits beyond the glycemic control. So even though they act at the peripheral level on the kidneys, nothing to do with your pancreas, but that is these drugs are having an extra glycemic benefits. So cardioprotective effects are there, renoprotective effects are there, and also pleiotropic effects are there. See earlier, no, all these things are because of the rosiglitazone story. If you see the backlog in 2008, a lot of the people died in the US following the usage of the rosiglitazone. So the reason is most of the cardiovascular deaths. So the people who are on the rosiglitazone are admitted in the ICUs with an acute myocardial infarction or heart failure, etc., and they are getting a lot of the mortality. Then the FDA has given a strong instructions to all the companies that whenever you produce any new anti-diabetic drug, that drug should have a cardioprotective effect, cardioprotection. So don't be happy with only with the glycemic control. So what we are much more worrying is these diabetics are dying prematurely because of your drugs. Even though they are reducing the blood sugars, they are causing a lot of the cardiac ill health and dying prematurely. So that is the reason FDA has given a clear instructions to all the companies that whenever you are producing a new drug in any diabetic management, you see that you do the cardiovascular trials and whether this drug is cardioprotective or cardiac harmful. If it is cardiac harmful, don't enter into the market even though they reduce the blood sugars. If they are cardioprotective, even though they are reducing the blood sugars, that drug should be available for the public for the usage. So that was the story in 2008. And then in the 2013, these SGLT inhibitors are entered into the market. So they studied first in the canagliflozin, the brand, the trial name is the Credence. So they studied nearly 4,000 diabetics. They taken all the diabetics and they studied all in the 4,000 diabetic individuals with this canagliflozin. That is a very good drug to reduce the blood sugars and also having the cardioprotective effects. That is passed into the market. Then the canagliflozin entered into the market. Then they studied the dapagliflozin. Now for the dapagliflozin, they have taken nearly the 4,000 patients, and out of them, 58% of the diabetics and remaining 42% are the non-diabetics. So even though they are taking the non-diabetics taking this dapagliflozin, they are having the more cardiac benefits and also the renal benefits. So that drug also passed into the market. So this dapagliflozin is good for the diabetes management. This is good for the cardiac management. This is good for the renal management. And then entered to the market is the empagliflozin by name Emperor or Empa kidney studies. So they say that this empagliflozin, the difference between the DAPA and the Empa here is in the both the studies they have taken the diabetics as well as the non-diabetics. 50%, nearly 50% of the diabetics, 50% non-diabetics. In dapagliflozin, they have taken the people with the GFR more than 30, whereas the empagliflozin, they have taken the people even at the GFR 20. So that means even in the stage 4 people, stage 4 CKD, also included in the empagliflozin study. And these two studies also passed with the highest marks with the distinction, like our Prabhu, who got very good marks in our recent PG entrance. At the latter time, I will introduce him. So these two drugs entered into the market with a big bang. So that is how these SGLT inhibitors entered into the market. Now these are the drugs that are useful in the diabetics and also in the non-diabetics, provided if they have the heart failure and the CKD. I hope I cleared your thing that these are not only the diabetic drugs, they are also cardiac drugs and also the renal drugs. So how the SGLT inhibitors are useful, how they are getting your renal protection and the cardio protection. On one hand, this is not all because of the diabetes management. This is extra diabetic benefits by these two means. One is diuresis, the second one is natriuresis. So these drugs, while using these drugs, they prevent the reabsorption of the filtered glucose. So all the glucose will be entered into the tubules, whether you are converted tubule or distal converted tubule, etc. Along with the glucose, they also block the sodium channels. So the sodium is also passes through the urine. So there will be the diuresis, there will be the natriuresis. So because of this diuresis, because of this natriuresis, your blood volume will be reduced. So that's how it reduces the preload and the afterload and gives the cardiac protection. So there will be also another process called tubuloglomerular feedback, not the glomerulus and the tubular feedback. First is the glomerulus, second one is the tubular. But by using these drugs, you will have the tubuloglomerular feedback. What it means? So when the sodium is passing through the urine into the collecting ducts, this causes a lot of the ATP formation. This ATP will be converted to the adenosine. This adenosine will act on your afferent arterioles. In the glomerulus, we will have the afferent and the efferent arterioles. In the afferent arterioles, they cause vasoconstriction. So that reduces the intraglomerular filtration and intraglomerular hypertension. So by reducing the intraglomerular hypertension and intraglomerular hyperfiltration, you are giving renoprotective effects. So this is the reason why the SGLT inhibitors are very useful cardiac and as well as renal drugs. Not only because of your reduction in your blood sugars, but also because of your diuresis, natriuresis, and tubuloglomerular blockade, and increasing more and more adenosine, and then reducing, causing afferent arterial vasoconstriction, causing reduction of your intraglomerular hyperfiltration and intraglomerular hypertension. So see the consequences. So reduces the blood pressure, reduces the body weight, reduces the A1C, that is your and also CV benefits and the kidney benefits. So now the mPOM, already I told you, the highest selectivity, cardioprotective, renoprotective effects largely independent of the glycemic control in patients with type 2 diabetes of established CP. So they compared to the sitagliptin. So you know the one of the best gliptins is the sitagliptin DP4 inhibitors. When compared to the sitagliptin, both are different drugs. But when compared to sitagliptin, the baseline HbA1c reduction is also good. And if you see the glucometabolic toxicity and improves the beta cell on the day 2 and the day 14, so plasma glucose will be reduced, fasting plasma glucose reduction by 25 milligrams. Good. C-peptide is increased. That means C-peptide increased means your endogenous insulin is producing very well. See the long-term durability. So I told you the glycemic pentad. So that means fourth one is the glycemic variability, fifth one is the quality of the life. So both things will be seen with this empagliflozin therapy. And if you see the sustained weight loss, it is also good. And you see the serum adiponectin level. This is the very important action on the fat tissue, your adipose tissue. See why Indians are having more and more ischemic disease because of abdominal adiposity. That is a vascular, that is a metabolically active. So we are unfortunately we are having the low adiponectin levels. Those people are having the more adiponectin levels will escape from the cardiac events. Those people who are with the low adiponectin levels, they invite the vascular events. So unfortunately, the diabetes, they will be the lower adiponectin level. By using this empagliflozin, that will elevate your adiponectin level and gives you the vascular protection. So this is the overall reduction. See the CV deaths, atherosclerotic cardiovascular disease, etc. Very good reduction by using this empagliflozin. So the major adverse events, CV deaths, all-cause mortality, hospitalizations, chronic kidney disease outcomes, all will be reduced with your EMPA-REG outcome trial. That shows clearly that empagliflozin scores over the other drugs as far as all these effects are concerned. See, this is the EMPA-REG reduced study. So you have the EMPA-REG reduced means your heart failure with the reduced ejection fraction. Now the heart failure is divided into three groups, REF and PEF and mid-range. So PEF means preserved ejection fraction. EF, when you are doing the echo, that will be more than the 50. In REF, reduced ejection fraction, that will be less than the 50. So somewhere between 40 and the 50. So even in those individuals, when the primary outcome and secondary outcomes, so there will be very good drug in using these drugs. So not only the reduced ejection fraction, maybe the mildly reduced or in the preserved, you will have a beautiful effects of the empagliflozin. So CV deaths also will be reduced. BP goal achievement. So the BP is also reduced without using any antihypertensive. Just by using empagliflozin, there will be the reduction of the systolic blood pressure to the tune of about 4 to 6 millimeters of the mercury. So that will be very good reduction in using these drugs. This is because of your diuresis and the natriuresis. See the systolic blood pressure reduction, renal production, so microalbuminuria and also the macroalbuminuria. Microalbuminuria means 30 to 300. Macroalbuminuria means more than the 300. In both these conditions, there is about 43 to 82% reduction in these cases. So kidney outcomes. So 32% reduction in the major kidney events like your proteinuria or your elevated CKD, etc. See that at all levels, it potentially delays the ESCD by up to 27 years. It's a beautiful, remarkable review. Suppose if you see the CKD today, if you start using these SGLT inhibitors like empagliflozin, you are preventing the end-stage renal disease where the dialysis or the transplantation needed by about the 27 years. So it's a very tremendous. Someone ఏమైనా కార్లు కొన్నాం అనుకోండి లీటర్ పెట్రోల్ కి మీకు 25 కిలోమీటర్లు వచ్చేస్తుంది 30 కిలోమీటర్లు పోనీ అట్లీస్ట్ 20 అని వస్తుంది అట్లీస్ట్ 15 అని వస్తుంది సో అవుట్ ఆఫ్ దిస్ 27 years even the 15 years is also very good for us to avoid or to delay the end-stage renal disease. So the kidney, so the same thing now, the CV deaths and kidney progression is also reduced. So cardiovascular deaths will be reduced by 28%. EMPA kidney study. Empagliflozin reduced the relative need for the insulin by 54%. If the person is getting the insulin, if you are starting on the empagliflozin, so the incidence of the requirement of insulin also will be reduced by using these drugs. With the metformin, so excellent combination. So metformin acts at the level of your liver, muscle and adipose tissue, whereas the empagliflozin acts at the level of the kidneys and also the extra key advantages. See, another advantage is empagliflozin that also acts on the fatty liver. So empagliflozin study, lift study is there that reduces your fatty liver when using these empagliflozin, a combination of these drugs. So the timing range, so I told you that the timing range is very important. That is your glycemic durability. So that also very good when you are using this empagliflozin with the gliptins. So what is more, it also acts on the obstructive sleep apnea. So now the snoring or obstructive sleep apnea. So the more and more people will have ischemic heart diseases. So vascular events. So there will be 52% reduction in the relative risk of new onset obstructive sleep apnea with empagliflozin versus the placebo. So another thing is hepatic fat content. I told you that the lift study, so that reduces your fatty liver incidence also. So this is the very well-known slide, ADA 2025. So in all the diabetic individuals, lifestyle measures are very important. After that, if the fellow is at risk of atherosclerotic cardiovascular disease, so start with the GLP-1 receptors or the SGLT inhibitors. If the fellow is at risk of the heart failure, start with the SGLT inhibitors. If the patient is at risk of CKD, so start with the SGLT inhibitors. So now the SGLT inhibitors are the important first-line drugs in the management of the diabetes. So this is the KDIGO guidelines on the diabetes management in the CKD. So the lifestyle measures, first line drugs, see the first line drugs in CKD. SGLT inhibitors, metformin, RAS inhibitors like your amitril or your telmisartan, and high intensity statins. So these are the very important. Then you can add the phenomenon also as the second line of the drug. So revisit our case. So the workup. So the risk factor profile, effective HbA1c and the metabolic control, lower the risk of hypoglycemia. Don't use the drugs which cause hypoglycemia. Beta cell independent mechanism. So don't bombard the pancreas by releasing more and more insulin by using the sulfurias. Reduction in the adiposity, inflammation, the BP. So this is the fatty inflammation, that is rising to CRP or adiponectin levels. Improvement in the insulin sensitivity. So by using these drugs. Target organ production, reduce the risk of the major adverse CV events, reduce the risk of the CV death, reduce the risk of heart failure, so reduce the risk of the kidney disease, reduce the hepatic fatty liver, and also risk like the obstructive sleep apnea. So thank you very much for your patience.